Good afternoon, everyone. Welcome to today's webinar. We're going to allow a minute or so for folks to get logged in. We have a good number of people that are registered for today's webinar, which is titled The ABCs of Autism Intervention. And we have some wonderful and expert presenters who are going to be sharing information and insights and perspective from the programs and resources that are available here in the state of North Carolina. We have representatives from the UNC TEACCH Autism Program, the Duke Center for Autism and Brain Development, and the Autism Society of North Carolina. My name is David Laxton, and I'm the Director of Communications at the Autism Society. So we appreciate you logging on to yet another Zoom presentation. We look forward to being back in person where we can share information, but for today, we are on Zoom. And this is going to be about an hour and 15 minutes or so of good information about this topic. Without further ado, I think we will have a message and we will be started.
Good afternoon and welcome to the ABCs of Autism Intervention. My name is Tracy Sheriff and it's my honor to serve as the Chief Executive Officer for the Autism Society of North Carolina. I am so pleased to welcome you all here today, along with our friends and colleagues from the Duke Center for Autism and Brain Development and the UNC TEACCH program. We're coming together today to talk about various therapeutic interventions for autism and provide you all with facts in an unbiased manner and without opinion. Our three organizations believe there is no one-size-fits-all therapy option for children and adults with autism. Each therapy is very different in the way it's structured, its time commitment, its service location, and its goals. As researchers, clinicians, and advocates, we also recognize that each person is unique, and individuals and families need to choose what works best for them. And sometimes there might be multiple right answers. We recognize that understanding what is offered and choosing what is best for your child and family can be very challenging. So today we're providing information to you about various therapeutic options from scientists and providers at the Autism Society of North Carolina, Duke, and the TEACCH Autism Program. Experts will provide an overview of scientifically proven intervention services available in North Carolina, such as ABA, TEACCH, and naturalistic developmental behavioral interventions, such as the Early Start Denver model. This webinar is something that we three could have done individually about the various modalities, but when we start discussing this concept and the need for it, we felt it would be more powerful if the three largest and most experienced organizations that serve individuals on the spectrum and their family could come together in a meaningful way. We three are all lockstep in how we feel about the benefits of evidence-based therapies and how they can be of benefit to a child or adult with autism. And to be perfectly candid, we want to acknowledge that there are a lot of misunderstandings, especially on social media, about what these therapies do and what these therapies do not do. This is our attempt to clear up any misunderstandings and provide you with clear and fact-based information so that you can make the best decision for your loved one. I welcome you to join this webinar, and if you have any questions or concerns, to have an open mind about what is being presented. We'll also do a Q&A at the end to answer your questions. Thank you and welcome.
We also appreciate Tracy's welcome comments. And at this time, I'd like to hand it over to Dr. Jerry Dawson from the Duke Center for Autism and Brain Development for a few remarks.
Hi, everyone. Welcome. I'm Dr. Jerry Dawson, and I direct the Duke Center for Autism and Brain Development. And at our center, we conduct research studies on different treatments, and then we also offer a wide range of services for infants through young adults. We have an interdisciplinary team that includes psychologists and psychiatrists, social workers, and nurses, and we try to provide an intervention that meets the needs of the whole individual, including both behavioral health needs and medical needs. I have conducted research in my own career on early intervention, and actually am co-developer of the Early Start Denver model that you'll hear about later when Dr. Franz is talking. I think she is the last speaker today. Now, we're so glad that you're joining us and that we can come together as three of the major organizations that do provide services for people on the autism spectrum. So it's wonderful to be here with UNC TEACCH program and with the Autism Society of North Carolina. And we're going to be talking about a lot of different interventions. But every one of those is evidence-based. And what that means is that there have been careful studies that have shown that these actually do improve the lives of people on the spectrum. So help to develop social skills, language skills. So they also have certain features in common. And these are very important features that characterize an evidence-based intervention. So I'm going to go through each one of those features. And as you listen to the presentations, think about how these features are showing up again and again. So first, families, and whether it's caregivers, brothers, sisters, grandparents, are part of the intervention team. And that's really important because we know that we don't want to see the intervention just occurring when you're working with a therapist, but rather that this is making an impact on your everyday life. And so if you think about during the day, every time you're interacting, whether it's with an adult with autism or a child with autism, that's an opportunity for learning. So we want parents to be part of the intervention team so that the skills that are learned are things that can be used throughout the day, and every interaction can be an opportunity for learning. The second feature is that they're individualized. So as you're well aware, every person on the autism spectrum is unique. They come with their own goals, their own strengths, their own preferences. And so every intervention has to be tailored to the individual. There's no one size that fits all. And third, you'll notice that the treatment goals are clearly defined and that they are measurable. And moreover, there's ways of collecting data over time to make sure that progress is being made. And if it's noticed that progress is not being made, that there's flexibility in always trying a new strategy to make sure that there's course correction and that you can continue to make good progress. And then finally, it's so important that there's good communication between the treatment team and yourself, as well as all of the other providers that might be working with the individual on the spectrum. And this often can include teachers, or it could be speech language therapists, occupational therapists. And it's very important that there's that interdisciplinary approach where all the folks are communicating together on the same page, and that you feel that you can always bring up your concerns and that the treatment team that you're working with will be responsive to them. Now, you'll notice today that these different interventions vary in their style and their structure. Interventions can differ in intensity and where the service is provided, and even the types of professionals that are working with the individual on the spectrum. And we know that often for a family, it isn't a matter of just being able to choose which intervention you want, but sometimes it's really what is available in your community or even what's affordable. So I want to leave with this last point that I hope will be reassuring to you, which is so far we have no evidence that as long as the intervention is evidence-based and does have those features that I just described to you, we have no evidence that the one intervention is going to be more effective than the other. And we actually do have clinical trials where they have randomized people to receive, for example, Early Start Denver model versus ABA, and to see whether are these interventions one more effective than the other. And so far the data suggests that they perform equally well in terms of helping the individual on the spectrum to develop skills. So that should be reassuring to you. And I'm happy to answer more questions about that point in the Q&A. So I'm going to end there, and I will turn it over to my friend and colleague, Dr. Laura Klinger, who oversees the TEACCH program.
Great, thanks a lot, Jerry. So as Jerry said, I am Laura Klinger. I am the director of the TEACCH Autism Program here at the University of North Carolina at Chapel Hill. At TEACCH, we have clinics across the state of North Carolina, and our goal is to provide evidence-based or research-based services to families in their home communities. So today I want to take a few minutes talking with you about how to choose the right intervention approach for your child. Parents often say, what is the best intervention? Which is the right one? And actually, probably a better question to ask is, what's the right intervention for my child at this particular time in his or her life? So you may choose one intervention for your toddler with autism, a different intervention for your school-aged child with autism, and yet a third approach for your adolescent with autism. And that is completely fine, because it's important, as Jerry said, for your intervention choice to be individualized to your child at that stage in their development. So given that, how do you know what to look for in deciding a good quality intervention or the right choice for your child? Well, the most important point, and the first point that I want to make, is the same one that Jerry just made. That research is very, very clear that parent involvement is likely to lead to better outcomes for your child, whether your child is a toddler, whether your child is in their school aged or even an adolescent. The parent involvement matters. It's very important to making sure that your child makes progress and is able to use the skills they learned in therapy outside of therapy in their everyday life. Second, research is also clear that treatment that promises a quick fix for very short amount of time is not likely to be effective. So for toddlers, interventions that occur a couple times a week are likely better than interventions that are once a month. We don't really know what the magic number is. It's 10 hours better than 5 hours. We really don't know, but we do know that interventions that occur more often or a couple times a week are better than monthly interventions. We also know that as your child ages and school aged, when you're asking for, say, mental health services to treat something like anxiety, that a longer program, like a 12-week program, is better than a short program. We do therefore know that interventions that promise a quick fix are not likely going to be effective. Third, Jerry talked about the importance of an individualized treatment plan, something that fits the needs of your child at this stage in their life. So what does a treatment plan look like? You know, what should you see on your treatment plan? What should you see during an intervention approach for a child with autism? So when I look across the different intervention approaches that you will hear about today, and in fact, across all evidence-based intervention approaches from toddlers through adults, my opinion is that all research-supported interventions usually have three things that are included. First, all the interventions that you will hear about today are teaching within routines. We know that children with autism learn best within routines. So all good intervention use routines to teach a new skill to your child. You'll hear about using play routines, an early start Denver model. You'll hear about using a routine strategy like a visual schedule in our structured teaching approaches. You might also hear about a routine for teaching calming or coping routines. Second, all good interventions include some treatment goals related to social communication. Autism at its core is a social communication disorder. So even when we're focusing on behavior management, we should be helping your child or adolescent or adult be able to communicate instead of having challenging behaviors. And third, all good intervention approaches involve some ways to help your child regulate their emotions, whether that be helping your toddler or your adolescent or even your adult figure out how to control themselves and regulate or use coping skills to be able to live a life with less anxiety. Last today, when I'm talking about choosing an intervention and thinking about intervention approaches for children, adolescents, and adults with autism. You want to make sure that your therapist has been trained to use the approach that they're using. So we talk about interventionists having good fidelity. So what does that mean? That means that your child's interventionist has been trained to do the therapy in the way that it was supposed to be done, in the way that it's designed. So it's okay for you to ask your therapist, are you certified in the intervention approach? Have you had training in the intervention approach that you're using with my child? Today, you're going to hear from certified interventionists about different therapy options that are available across North Carolina, approaches that are used at UNC, Duke, and the Autism Society of North Carolina. Luckily for families in North Carolina, all of these programs provide good quality, evidence-based services provided by interventionists who have been trained to do them well. So let me end today and introduce the next speaker. So our next speaker is Whitney, and Whitney is going to talk with you today from the Autism Society of North Carolina.
Thank you, Dr. Klinger, and I'm going to attempt to share my screen. All right, so my name is Whitney. I am from the Autism Society of North Carolina. My role there is director of our Lifelong Interventions Program, which is our comprehensive, intensive ABA program. So I'm really pleased and honored to be able to be here today and speak with you just briefly about ABA and what contemporary modern applications of the science looks like today. So a relevant starting point is really just trying to briefly articulate what is ABA and what is ABA not. So at its heart, ABA is the application of teaching strategies that are derived from the science of behavior analysis, which is simply the science of learning and behavior. Some hallmarks of ABA, and I think Dr. Klinger and Dr. Dawson have already done a great job of teeing me up for some of this, is that it's systematic, it's data-driven assessment and constant analysis of data to monitor progress and to make sure our goals and our teaching strategies are in line with best practice. And in the use of empirically validated measures. Those are major hallmarks of ABA. There's an established and ever-growing evidence base for ABA, particularly as a methodology for supporting the needs of individuals with autism. All of that technical language aside, at the heart of it, ABA is simply good teaching. And it's good teaching delivered through the lens of understanding our learners and understanding their unique learning styles, their characteristics, their preferences, and their intrinsic motivation. So there's a lot of jargon and technical speak when trying to describe what ABA is, but at its heart, this is the root of ABA. So like all sciences and all therapeutic practices, ABA has a present day application, and we also have a past. And I think it's important to speak to what I've described here as antiquated ABA. And I'm trying to use this slide to really juxtapose antiquated ABA with what modern contemporary ABA should look like in practice. So antiquated ABA, the ABA that is no longer considered best practice, really has a focus on being instructor-led and a heavy emphasis on behavior reduction and compliance with adult-delivered demands. Teaching is often decontextualized. Teaching strategies and reinforcers are often contrived and a little bit more artificial seeming. And sensory needs are often not considered or even disregarded. The goals from an antiquated ABA program aren't developmentally aligned and aren't functional for the individual and are often not meaningful or impactful for the family unit. Now, in contrast, modern or high quality contemporary ABA that I hope to talk with you about today is participant-led. The teaching opportunities are there, they are intentional and they are planned, but they're embedded within ongoing play routines or functional routines. That creates a meaningful context for teaching that makes sense to the learner and their family. Emphasis is always placed on self-advocacy, empowerment, and connection as the central tenets of the purpose of intervention. And the teaching materials, prompts, reinforcers, everything about that intervention is contextually aligned and rooted in intrinsic motivation. So no more sitting at a table working for M&Ms. That is aligned with antiquated ABA. Modern day contemporary ABA should look at the preferences and intrinsic motivation of the learner and align teaching strategies with already existing motivation. And finally, sensory needs are not only honored and accommodated, they're celebrated. And when behavior analysts aren't equipped to understand and address the sensory needs of the individual within their treatment sessions, they seek outside counsel with collaboration with other qualified providers. And the rest of this presentation is meant to go into more detail about these essential hallmarks of modern ABA, but if I could reduce it down to just a few bullet points, this in a snapshot is what contemporary ABA is trying to achieve. And the overarching objective of any high quality contemporary ABA program that, to Dr. Dawson's point, is implemented with fidelity should be enhancing the quality of life and happiness that is individually determined by the individual and their family. Those are the essential intended outcomes of any high quality ABA program. So what do these essential elements look like in practice? And again, circling back to empowerment, self-advocacy, and connection as the central tenets of ABA. It could look like individuals receiving support in the context that matter most to them, where they need to use the skills that they're learning and where they find value in learning and behaving. Looking for accommodations first and foremost before we seek to try to change behavior. How can we accommodate and change the environment to make sure that support, validation, and understanding are offered in every aspect of the program? And of course, sensory input is encouraged to be sought whenever needed in order to remain happy, relaxed, and engaged in sessions. Connection might look like the interests of the individual being highlighted and celebrated to make sure that the routines in which we are teaching encourage them to support, leisure and play activities that they enjoy. Social connections are only explored when they're valuable to the individual. So no more artificial teaching of social skills. Social skills is not the focus, it's social understanding, it's social connection in a way that the individual who is receiving the support finds valuable and meaningful to their life. As everyone has emphasized already, natural supports are empowered to be a central player on the team and to be active in all elements of programming. Self-advocacy might look like the individual having the right at all times to express their wants, preferences, needs, and ideas, even if those wants, preferences, needs, and ideas are not congruent with those of their caregivers or their instructors. Every individual has the right to reject unwanted experiences, to terminate undesired activities, and to negotiate for their desired outcomes. So self-advocacy in every form should be emphasized and taught as a fundamental, really human right, to the right to have effective self-advocacy skills. And those expressed wants and needs are honored whenever possible. And when they're not able to be honored because maybe it's not safe or just not possible, they're validated always. So to build successful programs, you have to have strong foundations. So I think some of these we've already, Dr. Klinger and Dr. Dawson already teed me up for nicely, but goals should be developmentally appropriate. They should be measurable, well-defined. Everyone should understand what we're working towards and how we're going to measure that, assess progress, and update and pivot as needed. Programming should always be developed first and foremost through the autism lens. This gets back to understanding your learner and how to teach through the lens of how they experience their world, and build upon strengths and interests and unique preferences. Families are a unit with everybody involved having equal, having their needs and contributions considered and valued, and be empowered to be active participants in the program. And of course, we always assess carefully before teaching, making sure that we're getting input and feedback from all relevant sources. That's all good and well in philosophy and sort of thinking about what is the purpose of ABA, but drilling down into what does high quality ABA look like in practice is a little bit trickier. So I hope this slide will give you an overview of some of the major foundational pieces to look for in a high quality ABA program. This could be a 2-hour presentation. I'm going to honor my time though, 15 minutes. So hopefully this will be a good resource slide for you. But first and foremost, the most important part of seeing high quality ABA in practice is seeing a strong therapeutic alliance. And by that, I mean the instructor and the learner and all relevant stakeholders having a relationship that is rooted in mutual trust and shared respect, and that everyone involved is happy, relaxed, and engaged in the session. Quality ABA is not teaching through power struggles. It's not teaching through tears. It's not about the instructor having more power over the situation than the learner. It's an equal alliance where everyone feels comfortable. Because where we're not comfortable, we're not learning. Those critical skills and concepts that are important to long-term success are broken down into teachable parts, and they are taught at a pace that does foster growth. It does push out of the comfort zone, but it's also delivered at a pace that feels comfortable and can foster that growth and long-term success. The teaching procedures are clearly defined. The instructors know how to teach, and they're doing it with fidelity, and they're doing it in a way that feels fun and functional, and where caregivers are empowered to understand how we're teaching and why. Intrinsic motivation is at the heart of everything that we do. It's emphasized as a priority above behavior reduction procedures or suppressing behaviors. We are looking at how to empower the learner through their own intrinsic motivation and reinforcers that are effective in the short and long term. And good teaching does not happen in a vacuum. Teaching success that only happens in a session in a therapy room is not success. So good teaching happens in multiple environments with a variety of instructors, including caregivers, and target increasingly complex situations so that true generalization can be achieved. So some quality indicators to look for if you are a parent or another stakeholder or an individual seeking support. Look for ABA programs that where you can see that your child or you, if you are the participant, are enjoying your time in the session, that you are engaged and connected and feel content. As a caregiver, you should clearly understand your role within the program and that you feel empowered with the knowledge to carry on the strategies that your RBTs and BCBAs, and those are acronyms I'll go in more detail about on my next slide, that you're empowered to use those strategies and understand how they work and why they work and how to use them yourself. You should look for ABA providers who believe in close, thoughtful, interdisciplinary collaboration. Look for behavior analysts who understand they don't have all the answers and that everyone is better on a team, and that they are willing to engage with relevant providers, share different perspectives, different ideas for the ultimate long-term outcome of the best possible results for your loved one and your family. You want to make sure that you feel empowered with the knowledge to work with your clinical team to monitor progress that's made in session, but more importantly, progress that's made outside of session toward the goals that matter most to you and your loved one. Again, quality intervention that's applied in a vacuum, that strategies that only work when the RBT or the BCBA use them, but never work for you as the parent outside of session, or never translate to school or to other relevant environments and stakeholders, is really not meaningful progress, because it's not making the impact on quality of life and happiness, which is our overall goal. So here's a snapshot of some important questions that you can ask when you're looking for an ABA provider and trying to understand if the organizations that you're speaking to share the same values and approach that you share for your loved one or for yourself. And this is just a snapshot of a few questions. And on my next slide, I'm going to allude to a resource that I think David's going to put in the chat for us, which is a more robust parent FAQ that will help you in trying to organize your thoughts around what should I be asking of potential providers to make sure that they're the right fit and that what they're practicing is high quality contemporary ABA. But one relevant question is determining who's on my treatment team, who's going to be in my home or at my child's school or at the clinic with my child. What are their credentials and what is their training? Some relevant players on most ABA treatment teams are RBTs, which stands for Registered Behavior Technicians. Those are paraprofessional level staff who are trained to implement the interventions, but they're supervised by BCBAs, Board Certified Behavior Analysts, who conduct assessments, develop the programs, coach and teach the RBTs and parents how to use these strategies effectively. So understanding who is on your team, what type of training do they receive, and what kind of ongoing supervision and consultation and mentorship do they receive even after the program has started. It's really relevant to understand how many cases your BCBAs oversee, what their overall caseload is. That helps you to understand what their bandwidth is going to be for you or your child in terms of the time they can designate to answering your questions and coaching your RBTs and coaching you to make sure that the programming is effective. What would a typical intervention session look like for my child? Picking up on some of those elements around what is the context in which you teach? Is it naturalistic? Is it child-led? What type of motivators or reinforcers do you find yourself using in your programs? And it's also really important to ask questions from the beginning of the process about what discharge and transition looks like. How long are individuals typically enrolled in your program, and how do you plan for discharge as the overall terminal goal? So I thank you for your time today. I hope this brief overview has been helpful. This resource slide does link you to a more in-depth overview of our position here at the Autism Society of North Carolina on applied behavior analysis, and gives a little more detail on some of the tenets of contemporary modern ABA. And like I mentioned, David will be sharing that parent FAQ in the chat with you. So I'm going to pass it over to Christina, and I look forward to hearing from you all during the Q&A.
Thank you so much, Whitney. So I'm going to be talking about the TEACCH approach to intervention with autism spectrum disorders. And I think, first and foremost, TEACCH is a statewide program that's been around a long time. And I think that's really important in thinking about how our interventions were developed and what we currently do. We're based at UNC. There's 7 centers across the state, and that means that we work with a lot of different people from a lot of different places in a lot of different situations at a lot of different ages. And so we're going to be talking about that because that greatly influences what we do as an intervention program. We have clinics. In addition, we have employment services and a residential program. So we are serving adults as well as very young children and doing some training. And over time, like starting as a statewide program where the initial mission was to serve all children in the state of North Carolina, you can imagine how that's no longer possible. So now our mission has changed a bit. There are too many children. You need all of us. You need ASNC, you need Duke, you need all of the providers in North Carolina to really serve your children and adults with autism. So now our mission really is to create and disseminate programs that are evidence-based, train other people and how to deliver interventions, and to really look at ways to increase quality of life. And you're going to hear some of these similar elements across our programs because, as Jerry and Laura pointed out, there are commonalities in evidence-based programs. And so hopefully you'll hear some of those commonalities, even though our programs are different. So again, TEACCH is a lifespan approach. And so I think that's something important to keep in mind. So when we're talking about our intervention, it's an intervention package that cuts across a very, very large age range, and it's going to look different at different points in a person's life. The other really important tenet is that it is based on understanding the learning styles of individuals with autism. So it really comes from this philosophy of how do they think, understand the world, and then how do we create interventions that really honor that. It is strength-based. It's antecedent-based, so it's sort of saying what are the strengths in the way a person with autism thinks or approaches the world, and then how do we take those strengths and harness them to make the world and learning as accessible as possible. And our approach is mostly structured teaching, so that's what I'll be focusing on. Like you've heard with other programs and from Laura and Jerry, the whole person view is important. So individuals with autism don't live in a vacuum, so we really need to consider what's around them when we're creating intervention. And then collaboration, and might be different at different ages. So it might be the schools when they're school age, it might be the parents when they're very young, it's always going to be the parents. And it could be, again, when they're adults, it might be their employers, or it could be their colleges. So we'll be talking a bit about that as well. So just to give you like a little snapshot, because we are talking about this big, broad age group, things are going to look different at different ages. So there's the Teach for Toddlers program, which really combines ESDM, which I'm not going to talk about because you're going to be hearing more about that from Lauren Franz and Jerry's group at Duke, but combines more of these naturalistic developmental strategies with some of these structured teaching approaches. In school age, we're doing a lot of training of teachers because the intervention can be delivered in a classroom, because it's the way you're thinking about a child, the way you're approaching them, and the way you're helping make learning accessible. It might be with parents. We have groups that, again, are blending, taking evidence-based approaches and combining them with structured teaching strategies, because structured teaching strategies are a framework where you can teach skills within. So we have Gorilla Group, we have Facing Your Fears, which are school age programs that may address anxiety, emotion regulation, which you heard Laura Klinger talking about earlier, which are targets for this group. For adolescents, you might hear about programs like T-STEP, a transition program, which really helps kids that are teenagers get to that adult stage and prepares them for more independent life after high school. And then there's adult programs, like I mentioned, like Employment Services or the Carolina Living and Learning Center, because we have a huge range of developmental groups, even within our adults. Some who need more support, some who need very little support. They can work, they just need some help. Some who need a lot more support where they need help with daily living kind of skills. So I want to talk a little bit about one of the most important tenets in any TEACCH program. This should be at the core or the heart when you're thinking about how do you know if you're really seeing someone who knows TEACCH well. It needs to start with the learning style of the person with autism. So how do they think, learn, and understand the world? We all, at this point in the field, think of autism as something that starts with the genetics very early. It really is affecting brain structure and function, which then goes on to create learning differences, which then goes on to affect the way they interact with the world. Communication differences, social interaction differences, behavioral differences. And that's the framework that we take when we're trying to create the intervention. So we have this tenet that individuals with autism learn differently, that their learning differences create unique strengths and challenges, and they really want to take both into account, and that we really want to value these strengths as well as help support the challenges that are coming up along the way. So when we think at TEACCH, the things that you'll hear about in terms of learning differences are their strengths in explicit learning. So as Laura Klinger said, really thinking about those rules and routines that we embed, and you'll be hearing those across programs. Thinking about how do we make things visual, because the auditory processing channel is often not quite as available to a lot of our learners with autism and our young ones with autism. Often they have a strength in really focusing in on details. Might seem irrelevant to us, but very relevant to them. And those details can be an advantage as well as a disadvantage. We think about it in part as a strength. And then having these very, very strong, intense, restricted interests and things that can be problematic, but as Whitney just talked about, we need to honor those too. And sometimes it's our window in, or it's our link into a whole other kind of world or avenue. And then we also think about those weaker areas. So a little bit more difficulty with implicit learning or just figuring things out by having been in one situation and going into another. Sticky attention, so getting overly focused on certain things and having trouble transitioning away. Difficulty with auditory processing, social cognition, and then executive function. So planning, organizing, time management, sequencing. So when we think about the pattern of strengths and weaknesses, and really that we're thinking about a learning difference, then what we think about in structured teaching is how do we really set up situations and strategies that decrease confusion and anxiety, because when any of us are anxious, we cannot take in information as well. How do we increase meaning and clarity? How do we increase flexibility, support generalization of skills across different areas or environments, and increase initiation and independence, which is important across the lifespan. Again, that's empowerment, as Whitney was saying. And so ultimately, we really want to increase engagement in whatever behavior we're expecting. So what is it that we want them to do, and how do we help make that happen? And that also helps ultimately to diminish challenging behavior. So we have 4 different types of structure that you would see across TEACCH programs. We consider, because of the learning styles, we say, okay, how do we organize the environment so it makes sense? What kind of activity systems do we set up that really help with that sequencing and organization that a lot of our children have difficulty with? How do we create schedules that help with flexibility and planning and sequencing at these different age groups? And then how do we think about how we give information through the strength-based arena? So visually structured kind of activities and cues. So this is just an example of how you might think about physical organization for a very young child. How do they know what they're going to do there? They have little books and things to do. And how is space defined? Because that can help organize some of our kiddos. In terms of activity systems for very young children, we might be thinking of just a simple left to right. Like we're going to get sort of washed up and brushed, then we're going to get our towel, and then we're going to get dressed. So just very simple way of showing a child a sequence of events and when it's finished and what it's going to entail. And then this is a little structured activity. So it's just all contained on one little cardboard box. There's not much to it in terms of organization, but it's a way of showing you have this many to do. You're going to be finished after they're all gone, and the child doesn't have to worry about all the materials and how they're arranging them. And then schedules, which many of us use, but for individuals with autism who have a lot of trouble with sequencing, planning, and organizing, they become even more crucial across all ages. So also when we're thinking about autism, and many of you think about an iceberg kind of viewpoint, and so do we, which is really how do we interpret challenging behaviors? And that's going to come from really our understanding of autism. So by nature of the fact that our children and adults with autism may have social communication difficulties or these learning style differences or sticky attention, that can then affect what we see from a behavioral point of view. But when we're trying to problem solve behavior, we're always thinking about it from this perspective of learning styles, which is what underlies everything that we do at TEACCH. So again, just thinking of TEACCH across the lifespan, there's different elements that you'll see at different ages, but they all are coming from this learning style perspective. They're all incorporating a child's strengths and interests and trying to accommodate some of their weaknesses to make them calmer and more receptive, open to learning, and more successful in that kind of environment. So for our very young children, TEACCH for toddlers, we use a combination of naturalistic strategies and structured strategies. And so you see some little activities there. Child's interests on the left, maybe in Thomas the Train or in Sesame Street, to help them with a developmentally appropriate activity, which might be building with blocks or doing one-to-one correspondence kind of activities. And you might also see things like little visual cues, so they know where to put things more easily. So where do things go? Well, the blue goes into the circle and the green goes into the square, for example. And then there is also the naturalistic strategies where you're coaching parents, working collaboratively with parents, and also on the floor playing or doing it during bath time or other times of the day. School age, you might see examples that also work in a school environment or classroom environment, or when a family is trying to set up a leisure activity. So you may see things like activities that, again, are sequenced and planned out so that the child doesn't get lost or overwhelmed by the amount of materials, which can then lead to a behavior challenge. Or you may see, again, different schedules for different age groups or developmental levels. Once we get into adolescence, so what you see down there on the right of that little blue box is from the T-STEP program. So you may see visual, highlighted, clear information on a social skill, like how do you plan for help when you need it, which requires asking somebody for something, knowing that you need the help to begin with. And so really clarifying that, so you think of it as, how do I teach this person this social skill of requesting help on the job as we prepare them for leaving high school and moving into another phase of their life. Or you might think about, how do I arrange the environment so it's clear where they're supposed to stand or what they're supposed to do, which is here in the gym. And then for adults, again, same thing. You're going to see these different strategies that really highlight and decrease confusion and increase clarity and meaning by saying, okay, how do we help someone, let's say on a job? If their job is to enter into a Excel spreadsheet, the different amounts that they may have from receipts. So you might think about color coding the spreadsheet, color coding the receipts so they can enter them more easily. Or you may think about what often we need when we're trying to put together something from IKEA. How do I keep not only the direction, but I put a picture too, if it's something confusing or new for a person when I'm giving instructions. So in terms of family or community collaboration, that's another big part of TEACCH. TEACCH came from that model, parent as co-therapist model, which was what it's called long ago. Now we use parent coaching, which is similar. A parent as co-therapist is this idea of shared expertise and people on equal footing. Parent coaching is very similar in a lot of ways, and we still use both depending on what age group we're working with. So we'd probably do less parent coaching with an adolescent or a younger child that's not a toddler or not a preschooler, but we're still going to be working with those parents in a co-therapist way. They hold expertise in their child, we hold expertise maybe in autism. And so we'll pull together and try to do what's best for the child. The collaboration, like I mentioned, may involve other people at other ages, and supporting teachers or students in the classroom might be something else that we're doing. And so we provide a lot of teacher training, and we can also consult to classrooms to help develop plans for students. And then we mentioned some of the programs for adults, like supported employment or employment services now it's called, and residential program, as well as T-STEP for the adolescents who are going into adulthood. And then also reaching rural families, because we're statewide. And I think it's important, and this was mentioned by one of our earlier panelists, that services and service availability really varies for a number of different reasons. And so we really want to be sure that we're getting information and training on evidence-based practices out across the state. And so the programs like Project ECHO are one way to do that, so that people can access services in their community. So that gives you a little bit of an overview of TEACCH, and hopefully it gives you some ideas of some of the elements that you might see at different ages and stages in the program. It's a pleasure talking with you all. And now I'm going to turn it over to Dr. Lauren Franz, who works at the Duke Center for the Autism and Brain Development. And she's going to talk to you about naturalistic developmental behavioral intervention and ESDM more specifically. Thank you.
Here we go. So good afternoon, everybody, and thank you so much for joining us. It's fantastic to be here with colleagues from UNC TEACCH and from the Autism Society of North Carolina. As Christina said, my name is Lauren Franz. I'm a child and adolescent psychiatrist in the Duke Center for Autism and Brain Development. And I'll be speaking today, providing a bit of information about naturalistic developmental behavioral interventions, which is a group of different intervention models for younger children, which actually share some similar characteristics. I will also then talk a bit about the Early Start Denver model, which is one of the naturalistic developmental behavioral intervention approaches. And it's the approach that we offer at Duke. So this is a busy slide, but it contains a lot of information, so bear with me. So naturalistic developmental behavioral interventions, or NDBI for short, involve the use of what we call behavioral principles of learning to actually teach skills from developmental sequence and naturalistic environments, meaning, familiar relationships, familiar play routines or home environments, but importantly using natural rewards, meaning that the rewards are sort of directly related to the child's response. What we also know about infants and toddlers, recognizing that these types of interventions are more for younger children, they're sort of experiential, hands-on learners. We know that relationships with adults, are very important to them, and that they can learn in those relationships through imitation. That these young children are visual, auditory, sensory learners. And we also know that everyday life routines are really important. We know that young children learn best when they're presented with skills that are just beyond the repertoire that they've currently mastered. So that's sort of ideal to provide challenges for the child to learn. And sort of within these sort of familiar relationships and these sort of familiar interactions, behavioral principles of learning are integrated, as well as behavioral teaching strategies. So this slide shows some examples of different interventions that fall within the naturalistic developmental behavioral intervention category. As I mentioned, the early start dental model is one of these approaches. And I've also included a screenshot of the first peer-reviewed publication that actually describes this broad intervention category. It was co-authored by many of the developers of these different approaches that you see on the slide. And in a way, the naturalistic developmental behavioral intervention category is a way of sort of moving the field from individual camps to more of a big tent approach, where we can start to look at what is sort of similar, right, across these different intervention approaches. So now I'm going to talk a bit about what are some common features that are seen in naturalistic developmental behavioral interventions. So these are all manualized interventions. They have established criteria that describe specific behaviors that affect child change. I think Laura Klinger spoke earlier about fidelity. That's what I'm talking about here. They include individualized child treatment goals. They ensure ongoing measurement of progress and include what we call three-part contingencies, ABCs of learning, antecedents, behaviors, and consequences, as well as incorporating behavioral instruction techniques such as prompting and fading. And very importantly, they include natural reinforcement and other strategies to help enhance child motivations for interaction. So importantly, interactions and activities are child chosen. These are child preferred activities. The child is the leader. The environment is structured in a way or arranged in a way to encourage child communication, initiation of communication. The adult imitates child language, play activities, and also what the child could be doing with their body. We work towards balanced turn taking, building that reciprocity, building that back and forth. And over time, the adult can work to sort of broaden the child's attentional focus. Activities and interactions, sorry, just hold on. So, as I've mentioned, these interactions occur during motivating child play activities or daily routines that are familiar to the child, right? And we incorporate behavioral instruction techniques within these interactions. Importantly, we are a big fan of shared positive emotions, shared positive affect, smiling, laughing, for a few reasons. So firstly, there is evidence to support that shared positive affect can help facilitate learning. It can enhance child motivation for interaction, and it can also help generalize sort of newly developed skills that the child is developing. What naturalistic developmental behavioral interventions also do is that they sort of help to expand the reciprocity, which is the back and forth I was talking about, communication, play skills, social skills, as well as sort of scaffolding the child in increasingly sort of age appropriate motor, cognitive, or adaptive skills. So this slide includes a screenshot of a publication by Carl Frost and colleagues, where they describe some common strategies that are used across quite a few of these naturalistic developmental behavioral intervention approaches during adult-child interactions. And with these combination of strategies, if they're used for a certain intensity, for a certain period of time, we would expect to see growth across child developmental domains. So just highlighting what some of these are. The adult and the child being face-to-face. In ESDM, the early start dental model, we talk about face-to-face and close enough to touch. Following the child's lead, recognizing that the child is the leader. These are child-preferred activities. Using positive affect and animation, which I spoke about earlier, recognizing that this can increase motivation for engagement and continuation, and it can also enhance learning and generalization of skills. It includes modeling developmentally appropriate language. So if the child is, maybe using word approximations, during a joint activity routine, the adult would maybe use 1 or 2 words, phrases, with languages actually appropriate to the materials and the context of what's actually going on in the interaction. Responding to child communication attempts, and these wouldn't just be verbal requests, verbal communication. It could be the child looking towards the caregiver. It could be the child pointing in the direction of the caregiver. So just really sort of sensitizing the adult to the communication attempts that the child is displaying. And then using communicative temptations to engage the child and to sort of encourage initiation of communication. And then this is the behavioral part at the end, sort of the frequency and the quality of the direct teaching that occurs in the joint activity routine. So now shifting a bit specifically to the early start Denver model, which I mentioned is the approach that we use here at Duke. The early start Denver model is one of the naturalistic developmental behavioral intervention approaches. I've included a picture of the co-developers of this intervention, Sally Rogers, who's at the UC Davis Mind Institute, and Jerry Dawson, who directs our Autism Center. So the early start Denver model is an evidence-based autism intervention for children with a solid evidence base currently for children under the age of 5. Like other NDBI approaches, it sort of integrates a relationship-focused developmental model with behavioral teaching practices. We know that autism impacts multiple developmental domains, not just expressive language or socialization. So what ESDM aims to do is sort of support growth across developmental domains and explicitly working on what we call the building blocks of social communication, things like joint attention and imitation, for example, during joint activity routines and child-preferred activities. So on this slide, I've included some publicly available books and other resources on the early start Denver model. And I've sort of recognizing the audience that we're predominantly speaking to today, I'm going to highlight 2 in particular with the blue arrows on the screen. So one is what we call our yellow book. And then our most recent ESDM iteration, which is called Helpers in Your Hands, which is actually a web-based caregiver and provider modules that are freely available. So the reason why I point out these resources is that they're being written and produced in a way to try and minimize jargon as much as possible and put them in a format that's as easily digestible as possible. We have a link to the Helpers in Your Hands materials on our Duke Autism Center website. And as I said, they're free and publicly available. I also want to highlight that the early start Denver model can be delivered in multiple different ways. It can be delivered through more of an intensive approach where an individual therapist would work with a child for many hours a week, but it can also be delivered in a group or preschool setting. Importantly, you can coach caregivers in ESDM strategies, which is what we do primarily at Duke when we're working in this intervention approach. And fortunately, with COVID, we can coach caregivers using telehealth, right? So that's a great way of disseminating the work that we do to communities that are harder to reach. And I'd just like to end with this slide. I think most of our panelists have mentioned it on, some tips for caregivers and parents who are thinking about, what therapy approach may be best suited for their family. Just making sure that you speak with prospective providers and asking more about their approach. How does it fit with your child? How does it fit with your family? How does it fit with your goals and priorities? Does it sort of really emphasize meaningful skill development? Are folks ready to sort of tailor the intensity of what they do to individual child and family needs? And do they encourage multidisciplinary supports? And then very importantly, is the child and the family involved in actually identifying meaningful treatment goals? And then lastly, just making sure, and I think a few of the panelists have mentioned this, that progress is actually measured, progress is actually tracked. Like, how do we know that we're moving in the right direction, right? So with that, I'll wrap up, and thank you so much for your attention, and I'll hand back over to Tracy Scherer, who I think is going to be moderating today.
Thank you so much, Dr. Franz. First, I want to thank all the attendees for attending this webinar. One of our goals was to provide you with a facts-based information about the benefits of evidence-based therapies and how they can be of benefit to your child. So I hope you feel we achieved this goal and that you found this content helpful and relevant. Also, just want to take a moment. I want to be cognizant of our time, but I do want to thank our presenters for their time and expertise. So thank you to Whitney, Dr. Laura Franz, Dr. Christina Corsello, and of course, we want to thank Dr. Laura Klinger and Dr. Jerry Dawson for helping bring our three organizations together for this webinar. So at this point in time, I want to open up the webinar for some Q&A. So I'm going to select some of the questions that were made during the webinar and then direct them to some of our speakers. I'm going to pick a speaker, but then if there are other panelists that want to jump in and help out as well, feel free to do so. So Dr. Corsello, this question popped up during your part of your presentation. Does a student need to be a current client to access the school supports you just mentioned?
So not necessarily. I mean, there's different ways to get help from TEACCH in the school system. One way is if the school has a contract with TEACCH or establishes a contract with TEACCH, then we can help in that way. So sometimes we help the school system, or there are certain teachers within a district that need support. There are other times where a student themselves and a family want some help and support, and then we just want to make sure the school is on board and inviting us in and a part of that. So a family can be referred for services in any way. It's usually helpful for us to get to know the student some. So I think that they don't necessarily have to be a client now. They could be referred for that purpose, but we would probably want to get to know them a little bit individually in order to provide consultation in the school if it was on an individual client level.
Thank you for that. So the next question, I'm going to start with you, Dr. Corsello, and this is something that we'll probably have each organization answer themselves. The question is, in addition to the locations throughout the state, do you have programs that send therapists into small rural schools to teach the teachers?
We do. So TEACCH does that in two ways. TEACCH has a very large teacher training program, which right now is running virtually. At better times, we have people actually come here, or we go out to different locations in the state, outside of the state, outside of the country, and provide training to teachers. So that is one thing that we do regularly. And then our clinics may have contracts with districts where they may actually go into the classrooms and provide, coaching, consultation to teachers. So two different ways, and that is across, either one is available across the state.
Yeah. Whitney, would you like to fill that? And then Dr. Dawson and Dr. Franz.
Sure, yeah, the Autism Society also has a separate wing of our clinical department, which is specifically for training and education, that's headed up by our Associate Clinical Director, Dr. Louise Southern, and she orchestrates a lot of trainings across the state with different stakeholders, specifically school systems and others, and certainly always trying to reach different nooks and crannies of the state. So that's something school systems interested in. I'm sure that Dr. Southern would be able to explore that need with you.
And I think we're going to tag team. So Lauren, why don't you start and then I'll make a quick comment.
So I'll sort of recognize that in educational systems, 3 to 5 years old, 3 to 5 year old kids, and then younger than that within the home environment. So I think we recognize that there's a huge need to disseminate best practices, and we have a growing partnership with both 3 directors and providers across the state to pilot programs where we skill up community providers in in early intervention strategies. So I think watch this space. We recognize the tremendous need, and we're sort of actively working to partner with state providers to fill it.
Now, the other way that we are providing that kind of training is really just through the trainees that come through our program, who often end up going out into the community. So we have many, many trainees that come through on for a practicum or for an internship that then go out in the community. And that's one of our main ways of disseminating.
Great. Thank you all for that. Whitney, I'm going to turn this question for you, something I'm sure most people are interested in. Is insurance required for these types of therapies?
For most providers, insurance funding is not necessarily required, though it can obviously be a really costly service. So having some sort of funder backing, whether it's commercial health insurance or Medicaid, usually is necessary to make this feasible for most families. And most insurance providers at this point are funding these types of services for families. Obviously, everyone in this room did a lot of work on insurance legislation several years back. And so it's much more available to families across the state at this point, and it's also available via Medicaid funding. And it can be complicated, and certainly for most insurances, prior authorizations required. So there's some hoops to jump through, some approvals to get before, even if you have that funding available, before they will pay or reimburse your provider for services. So it's important to do your due diligence on making sure that even if you have the benefit, that you and your provider have done everything necessary to make sure that it will be approved, it will be funded, and your provider should help walk you through that. They should be providing guidance and really handling a lot of the insurance funding, if that's the avenue that you're using to seek reimbursement for the services, should be supporting you in that, because it's confusing even for those of us who deal with it every single day. And you as caregivers really should have their support in navigating the insurance piece.
Yeah, very good, thank you. And I'm going to do it's a separate question, but a follow-up to you, Whitney. This came in during your presentation in reference to modern methods of ABA. So the person asked, what, if any, changes are being made to ensure ABA providers or private companies are transitioning to modern methods?
That's a great question. And, I think the answer to that is that it's an evolution that is in process now. As ABA providers, we've always had an ethical board that we answer to and that guides our practice. And as more and more discussions about what high quality contemporary ABA should look like, and a lot of these discussions are really generated in spaces where self-advocates are really advocating for changes that need to be made, and providers are listening and being responsive and pivoting their approach. There's also been secondary ethical boards that have come about in the last several years. So one is an organization called Behavioral Health Centers of Excellence, or BHCOE, and they're an accrediting body that's offering a really thorough accreditation process for ABA providers to ensure that their methodology is in line with everything we talked about today in terms of high quality contemporary ABA. So I would say look for those accrediting bodies that continue to kind of come out of the woodworks, that are looking for not just those standard, ethical guidelines that we have to honor for our licensing boards, but also for those accrediting bodies that are looking for the quality of the intervention that providers are offering to their community.
Yeah, very good. Thank you for that. I'm going to turn this question over to our university colleagues. The question is, how can university partners with local communities across the state to provide high quality autism services?
Well, that's a big question. So, well, first of all, it's absolutely essential. So we have a community engagement advisory board that is comprised of many of the leaders in the areas of education, also healthcare. Some of these are more education at the elementary and older age, as well as people who are leaders at the state level in the area of birth to 3 centers or early intervention. And it really is through that partnership that we have been developing models of dissemination and really also learning more about the needs at the state level. And for example, it's out of that partnership that we have now partnered with the Birth to Three centers to provide training to the people who are out in the homes, right, providing early intervention that is paid through the government. So I think the first step is obviously that communication, and then learning the needs, and then developing ways of disseminating.
If I can just tag team, sorry.
Go ahead, Lauren, go ahead.
Just really quick. So I think another key thing is packaging information in a way that it can be disseminated and in a way that is accessible. I think that there are lots of initiatives around that now because that can help disseminate best practice. And then also thinking about potential innovations and training. And what can we do differently, right, to train and get folks to fidelity in certain strategies. So.
And Tracy, if you don't mind if I make one more comment, because one thing that we haven't talked a lot about, that's something that Duke has really emphasized, has to do more with the medical care and psychiatric care. So we know that as children develop, it's common to develop psychiatric comorbidities. It could be anxiety or depression, and also that children on the spectrum, adults, have a lot of medical conditions that go along with autism. And so one of our strong emphasis at Duke has been, as I mentioned in the beginning, is this sort of holistic view of addressing both the behavioral and the medical needs. So for example, one of our programs that we partner with is called NC PALS, and it is a sort of technical assistance program where we have psychiatrists on call that can address the questions of psychiatrists and other doctors, pediatricians that are out in the community, for example, in rural areas, so that when questions come up about how to serve the needs of people with on the spectrum and those with intellectual disabilities, that they can turn to someone who has a lot of experience. So that's been an area that we have had a strong focus on, because we felt that it was an area that has been to some extent not emphasized as much, but we think that holistic view is really critical, important, the physical health as well as the behavioral health.
I love that question, because that's really the mission of universities, is to partner with our communities to make sure that we're bringing good quality services to families in their home communities. That's the mission of the university broadly, and in this case, in the area of autism. And I think you heard a couple really great examples of that. At TEACCH, I think we work collaboratively with the Department of Public Instruction, really focused on making sure that we're providing opportunities for teacher education and training. We also work collaboratively with other entities. Like, we have a program actually that collaborates with the Autism Society of North Carolina and with Duke on bringing rural providers good quality professional development opportunities. So the program I'm talking about is called Project ECHO, where we're working on providing professional development both to primary care providers in rural areas across the state, but also mental health providers across the state. And then I think we also need to look across the lifespan. So one of our focuses right now is to partner with our community college programs. A lot of students with autism are leaving high school and going to community college. And at TEACCH, I know that we're currently working with 7 different community colleges around the state. So I think it's the mission of all universities to figure out how to partner with our community providers and make sure that what's happening on campus is not just true in our Ivory Tower campus, but out in the communities. And I think what you've heard from ASNC and Duke and TEACCH are all really great examples how we're all working to make that happen, because not a single one of us could do everything that's needed in the field of autism.
Well said, thank you. So I'm going to pull a moderator audible here. We had some technical difficulties in the beginning. We still have quite a few like really good questions. So I'm going to see if our panelists can hang on with us just for 8 more minutes. We can just go to 1:30. We wanted to keep this presentation condensed, but we just have great speakers here with wonderful clinical knowledge, and I just want to take advantage of that. We just have a couple of really other good questions. So if I can peer pressure you all to hang on for a couple more minutes, I'll go to the next question. Thank you. I love this question. How do you know if you need ABA, or how do you know what your child needs? Our son was diagnosed in October of 2020, and we've been lost ever since, and we don't know which services, aside from his IEP, or where to start to help him. And I will turn that over to anyone that feels compelled to answer.
I'll jump in and say that certainly if your child is recently diagnosed, you probably do need some services for him. It would be great to get him in some services, like I said, that provide additional supports, more intensive, more long-lasting services. I think you heard today that you can get those services at Duke, you can get those services through AUTIStic or through TEACCH. So I think I know that at TEACCH, and I think also at the Autism Society, I don't know about Duke, we have referral and resource specialists that you can call and ask about what is available to you in your area of the state. You can ask about what services are covered by your insurance so that we could get you directed toward the right service for you. If you call TEACCH, it may be that we direct you to a TEACCH service, but we may send you to a service at Duke. So I think what I would encourage you to do is to reach out and talk to one of our autism resource specialists to see if we can't get you and your child directed in the right way to make sure you're getting the services you need. But my guess is that yes, your child probably does need some additional services. If we can get you hooked up to the right ones in your community, that would be outstanding.
Yeah, and just as a brief follow-up, I mean, I think that what Laura said is key, which is to connect with one of the organizations that has expertise in this area. So whether you call TEACCH, or if you called ASNIC, or if you call Duke, you're going to connect with someone that will not leave you until you have gotten connected to the right services for your child. And often, and we at Duke have the same service, which is that when someone calls in with a question, it's many times we're not saying come to Duke, where we know the services that are out across the state, and we're connecting people with the right service in the area and the community that they live in. But starting with working with someone who has expertise in the autism field, and they can evaluate the needs of your family and your child, and develop basically a plan for you and your child, where you can get services, what's going to be the best approach, how you can connect with the right schools and professionals. So getting that guidance, I think, right in the beginning is essential. And there's, you know, a lot of good organizations represented here and elsewhere that can help you with that.
Yeah, and I would just add also, and David, maybe you can put this link in, if you can call our autism resource specialists. They are all moms of parents with autism, and they field all types of questions, lifelong questions, from newly diagnosed questions, IEP, transitioned, adult questions, and we answer them when we can. And often we refer to our partners here on the webinar and to many other folks there as well. So they're a great resource. We field over, I think, 6,000 calls a year. So they're very well versed in this. Just understand the need is high right now, so we'll do our best to respond to you quickly. Okay, moving on to our next question. We've got about 4 minutes left. We've got several questions about things happening out of state, and just for time purposes, I'm going to try to focus this to North Carolina. So I apologize if I'm not going to get to every question. Whitney, has any progress been made to provide ABA therapy in public schools?
Yes and no. I think that in terms of how the Autism Society has tried to address what is a really important concern, you know, we think about how children with autism access intervention and support where they learn. By and large, that's in the public school system. So empowering our teachers, our educators, our instructional assistants with the tools that they need to really support all of their students is of utmost importance. Obviously, there's still a lot of barriers to providing quote unquote ABA in the schools, but our approach has really been to try to through training, through coaching, through consultation, all of the ways I think all of us have spoken about external stakeholder training and support to empower with the information and knowledge about best practice and how ABA could look in your classroom, in your school system, and empower the actual educators and instructional assistants with that knowledge versus really spending most of our efforts and energy on having our intensive programs in the school. Because really, as we're planning for long-term outcomes and for a child to be set up for long-term success at school and to be ready to learn and to feel safe and supported and able to communicate, where they're spending most of their time, which is in their classroom. We really want to empower those important stakeholders with the tools to do that.
Anything to add from our other panelists regarding that? If not, I'll move to the next question. Okay. Dr. Corsello, this question seems relevant to your presentation, talking about lifelong services. So the question is, can someone tell me if such interventions are required lifelong in order to maintain developmental skills?
So I think that, what happens with someone with autism is the needs change, and the needs for what kind of skills you might need in a different environment change, and whether or not you continue to need support can change over someone's life. So it's a hard question to answer in general. What I would say is that that we are all lifelong learners, right? So the one thing I would say is for any of us, there's not like a day where we suddenly stop learning. Like I'm learning every day and I'm middle-aged. So I think that there's always room to learn for any of us, and that nobody should have the idea that at some point for individuals with developmental disabilities that there's some day that they just stop learning. I think that would be a mistake. So I think we are all lifelong learners. There are always opportunities for us to learn. I think that there's some people who may require more learning and support even into their older ages. And there are some people who, as they grow and develop into adulthood, may need very little support. So you may see big changes over time. So it's hard to answer, like people have been talking about this individualization idea. Right. There's not a one size fits all. And for some people, they may need more support. Some people may not. But I think the important thing in sort of my mind is someone who thinks about lifelong intervention is that we're all lifelong learners and that we should all be providing continued opportunities for learning and growth for any of us.
Yeah, well said. Thank you. Okay, I'm going to take one last question and then wrap up our webinar. I would encourage everyone to check out each organization's respective site. There's questions about diagnostics and training, and I think a lot of those we have those on our websites too. So I'm sorry we can't get to all the questions. But I think some of those can be answered on our website. Final question. As we enter adolescence with autism, it feels like we're in the wilderness. Adolescence plus autism is a challenging equation, especially with emotional impacts. It seems like so many services are for early childhood. What now? And I'll turn that over to anyone who feels compelled to answer.
Well, I'll just make a quick comment and then let others respond, which is to say, at least at Duke, and I know this is true of the other organization, is that we, even though we talked about Early Start Denver model, which is a treatment that is delivered to young children, we see individuals through, out the lifespan into adulthood, and adolescence is a large part of the population that we serve. And there are so many, just like for every adolescent, there are so many new challenges that come up with adolescents. It can range from, feeling anxious about how you develop a social relationship, to issues around sexuality, to how do I navigate, a school environment now that's much more demanding than it ever was. And so an autism professional is very used to those kinds of questions. And we have an entire toolkit, right, of different kinds of cognitive behavioral strategies and skills development programs that help us address every one of those areas. Again, ranging from issues around depression or anxiety, to simply, I'm not making progress in my classroom and don't seem to be learning well, and my learning style doesn't fit with the way that the teacher is teaching. So those are the kind of questions that organizations like ours are very used to, and we have quite a few professionals with lots of tools in our toolkit to help families that are struggling with those kinds of questions and adolescents.
Dr. Klinger, do you have anything to add to that?
I will say that the research on, what we know about interventions absolutely started out looking more at early interventions, but you're going to see more and more work being done to know how to help and support adolescents into adults and even older adults. And absolutely all three of our organizations are expanding our services, or have always expanded our services to include adolescents and adults. So we don't want families to feel that they're experiencing that cliff. I think they could get services to help bridge between leaving the school and entering adult services at any of our programs.
And anything to add, Whitney, to that?
Would just piggyback off of that and also say, in terms of funding and access to services beyond early intervention, if it's been a while since you've looked into that for your child, a lot has changed in the funding landscape in the state over the last 5 to 6 years. It's definitely worth revisiting and reaching out to all of the stakeholders here for information about what might be effective, what might be relevant, and how to tap into ways to pay for it.
Okay, very good. Well, on that, I think we will wrap up. I feel like I've extended all my moderator authority that I have and pushing us about 20 minutes over. And I feel like we could continue talking about this all afternoon. So I first and foremost want to thank our attendees for joining us. All of our organizations value you and feel fortunate that you're coming to us for some of these answers. So thank you. And then to our presenters, couldn't ask for better speakers and better content. So thank you all so much for your time, and wish you well. And again, this will be posted on, I know, the Autism Society's website, and I'm sure we'll share with our partners on this webinar as well. So thank you all so much and have a great day.